everyone for your attention this morning. Because we are running a little bit behind schedule, we're going to proceed with presentation number 4. So I'll quickly introduce myself. My name is Sarjana Alam, and I am a CDTRP trainee at the University of Alberta, working on basic science research in transplantation. Today, I am very pleased to introduce our speaker for our 4th session, who will be speaking about network environment for Indigenous health research. Dr. Roberty Henry, Dr. Robert Henry, is Métis from Prince Albert, Saskatchewan. He currently holds a Tier 2 Canada Research Chair in Indigenous Justice and Wellbeing and is the nominated Principal Investigator and Executive Director of the Saskatchewan Network Environments for Indigenous Health Research, or the NEIHR. The NEIHR program has set the foundation towards establishing a national network of centers focused on strengthening Indigenous research capacity, training, and mentoring, and supporting Indigenous community-based health research that reflects the priorities and values of Indigenous peoples. The Saskatchewan NEIHR Centre focuses on a distinctions-based approach to data collection and management, accurately distinguishing data on Métis people or First Nations people from pan-Indigenous data. So with that, I'm very pleased to pass it off to you, Dr. Henry.
All right. Thank you very much, Sarjana. Good morning, everybody. I apologize. I'm actually at Kelowna Airport. It's a last-minute flight I had to take here. So, but I'll do my best to go through, and I hope everything works well here. So thank you for the introduction. For those of you, my name is Robert Henry, or Robbie. As Sarjana was saying, I'm Métis from Prince Albert, Saskatchewan, and I am the lead for the National Coordinating Center for the Network Environments for Indigenous Health Research, as well as lead the Saskatchewan Network Environments for Indigenous Health Research. I also lead the Indigenous Engagement Platform for the Canadian Research Initiative in Substance Misuse. And I do a lot of work looking at distinctions-based ethics, data governance, data sovereignty, and so forth. I haven't prepared a PowerPoint slide today. I'd just rather have this as a conversation with with everybody who's online here on just different ways to be thinking about research, what the NEIHR network is, and so forth. So the NEIHR network itself is set up as 9 different provincial, territorial, and regional networks across the country, with a 10th starting here soon in with the Yukon. This network should be understood as a network of networks. So it's led by different PIs. Each NEIHR is independent. They focus on the community engaged research or the community priorities within that region, within their space. And with the NCC, or the National Coordinating Center, is I work across all the NEIHRs and work directly with the Institute of Indigenous Peoples Health to try and shape, support Indigenous health priority research nationally and internationally. When we think about the NEIHRs, one of the things that we have been emphasizing is the idea or the importance of capacity building. How do we build the next wave for individuals to move into Indigenous health research? What is the training that goes on? But within this, we're also not just training the next generation of researchers, we're also looking at providing training and education for communities on what is research, what is data collection, how do we go about developing ethics protocols, really just trying to prepare communities and Indigenous peoples who are looking at participating in research to understand their rights and responsibilities with it. For this presentation here, I was asked to talk about 3 sort of broad areas. So the first is a distinctions-based approach. One of the things we have to remember within research is when we use the term Indigenous, it is to actually encompass First Nations, Métis, and NEIHR. One of the things that we have been pushing very, trying to educate individuals on is that if we continuously use the term Indigenous and only use First Nations data, we are misrepresenting the experiences of Métis and Inuit people in here. So as researchers, you need to be very clear on your population that you're using. And if you're going back and forth between these terms, you need to explain to the reader, to the community, to those who you're presenting to, why it is that you're moving from First Nations data to Indigenous generalization of information and facts. With this, um, with the distinctions-based approach, why it's important is that we have, or generally, we have very good, in relation to First Nations, Métis, and Inuit, we have very good data on First Nations, but we don't have data on Métis, and we have a little bit more with Inuit on experiences within health systems. But because of the way in which data has been collected, it's been interpreted, and the access to specific communities, we see an uptake with First Nations. But what happens then is we take First Nations experiences and apply them onto other Indigenous groups in Canada. So the First Nations with the Métis, urban, and Inuit. In Saskatchewan, what we've looked at doing with the Saskatchewan year is really emphasizing sort of two streams because we don't have a large Inuit population. It's very, very small. So we do, but we do have First Nations and Métis. And we also have to recognize that in northern Saskatchewan, we have First Nations communities living right next to Métis communities. But their experiences within healthcare systems and delivery are vastly different. In northern Saskatchewan, you have medical buses for First Nations where they're able to access their care for dialysis, where their travel costs are covered. For Métis, those travel costs aren't covered. It has to come out of their own pocket, or they have to find other ways in which to do this. This is where the complexity comes in here, where if we're looking at determinants of health, when we look at northern First Nations and Métis communities in Saskatchewan, we have to understand that Métis are actually have more social determinants of health to access care, which has a huge implication on tracking on individuals even going um, into their doctor for regular checkups. So, for example, we worked with individuals who have had to travel 6 hours just to get a doctor's appointment. So that means they've had to take a full day off work. They've had to take a day of travel. They've had to pay for that. They've had to pay for their hotels, and so there's this burden of cost. And so some things that I think are important to look at are with Métis specifically in Saskatchewan and Manitoba, in northern communities. Uh, are they actually following through with their dialysis, or are they just stopping because they don't have the ability to travel or the funds to go back and forth within this? Um, so this is something we need to look at and differentiate so that we don't homogenize Indigenous experiences across Canada. As the earlier speaker said, if we go to the northwest of Ontario, those experiences of going to Toronto are really important versus somebody from Six Nations who are going to Toronto for the same, for looking at kidney disease or kidney transplants or so forth. So be very different on that. But so we need to be careful of homogenizing sort of these experiences to say that this is what the Indigenous experience is. The other piece that we have to understand, and it was brought up in the other presentation, which is great, but I also sit on the Global Indigenous Data Alliance. And one of the things that is continuously it's understood in Canada that OCAP is the gold standard for Indigenous data sovereignty. But we have to understand that OCAP is only First Nations specific. It does not recognize Métis data sovereignty and governance. It does not recognize Inuit. It is a First Nations state status approach to understanding how to do this. For Saskatchewan, what we've done then is we've worked myself, with the guidance and leadership of Dr. Caroline Tate, have brought forth Métis data principles, which we are looking at inputting into the Chapter 9, because I sit on the next iteration. We're redoing Chapter 9 for the TCPS2. So we're going to be inputting more Inuit specific data governance models, as well as Métis data governance models within it. The other part, and I think this is a bit bigger when we look at a distinctions-based approach, is that it forces researchers to go into the community to begin to understand the history and the cultural nuances that are happening within this community. For example, in Saskatchewan, just because of Métis, the North and the South Métis are very different in their cultural, in how they go about understanding the world around them. In the North, very much, there's a strong Christian component. There's ways in which but there's a very strong language up there that focuses more on Cree and Dene dialects that are happening. Where in the South, there's Chip and a stronger focus to Indigenous spirituality rather than Christianity. So this is where, even just in Métis within Saskatchewan, we have to understand the local communities are different. Why I'm saying this is that what has happened in the past within health research, and I don't think it's to put blame or pressure on anybody, but what we've done is we began to take concepts or constructs from other First Nations places across the country and adapted them as though they are a universal understanding of Indigenous or First Nations or Métis or Inuit um, understandings of relationality or how research should be done. The biggest example, the two big examples that I can talk about, and the first one is two-eyed seeing. Two-eyed seeing is a Mi'kmaq understanding of relationality between the Mi'kmaq people and colonial research histories. It is constructed within their territories. It's been understood there. We can see that the conceptualization is there, but we see First Nations have other ways of understanding this that are more locally directed or have a stronger local connection to where they are. For example, when we look into Haudenosaunee, we shouldn't be using two-eyed seeing now. We should be looking at the wampum belt and how the wampum belt understands the two rows moving side by side, which is similar to what the two-eyed seeing is stating, but it's a different way of relating to space and place. When we look into the prairies, we have other references that we should be looking at. We can be looking at the medicine wheel. We can be looking at, with Métis people, we can be looking at the sash and the way the sash is represented for relationship building and research and so forth. So we have to be careful on how or why we're adapting this into these communities and understand that by just adapting a two-eyed seeing approach into a Cree perspective, we're missing the point of why it was created in the first place. And we're seeing now within Mi'kmaq communities that there is a reclamation of the term two-eyed seeing to say this is our term, this is who we are, and it shouldn't be used outside. You can learn from it, but you shouldn't be applying it. And so we're beginning to see this sort of fight back across these different spaces. Another one that we're seeing within knowledge mobilization quite a bit across the country, and this is something that I think, as physicians and researchers need to really understand, is the medicine wheel. And that this medicine wheel is a conceptualization of health. Again, the medicine wheel isn't applied across Canada. It's not applied across all Indigenous nations. It's very specific into where it is, and it's primarily it's a Cree, Anishinaabe, and Plains First Nations understanding of relationships. However, we're seeing this being applied as, okay, this is what health looks like. This isn't to say that we can't conceptualize it. It's that we need to contextualize it within what we're talking about. We have to make sure that we're recognizing the local First Nations, Métis, Inuit communities, knowledges and experiences when we're developing tools that we're looking at informing and improving health facilities or healthcare practices. So this really comes down to the researcher. And I think we really need to understand with researchers and research teams, if we're going to be building ethical, community engaged research practices, we need to start sitting down with the community and begin to understand what are the values, what are the cultural nuances that are happening within that community so that we are not misappropriating information. And when we develop knowledge mobilization tools, that they're actually reflective of community understandings. I want to just put a point. I know this is outside of your work, but myself and a grad student, we have been doing work related to programming, pan-Indigenous programming within the justice system. And where the justice system has created programs to say, okay, this is what you do to become Indigenous. And what we're seeing is that individuals who are going into these programs who are Indigenous and going back to their communities of their First Nations, Métis, Inuit, and they're bringing these teachings, their actual engagement of identity and where it's supposed to be uplifting is actually dropping because the teachings that they're getting within the institution are not reflective of their community, and people are basically saying that is not who we are. And so it has an impact post engagement. So if we're looking at urban spaces, and we're looking at navigators within this, we have to make sure that the navigators are reflective of the First Nations, Métis, or Inuit who are actually needing those services. Meaning that you should never have a Cree navigator working with, like, explaining, here's what's going on for a Dene person. The language is different, the understandings are different, and so the experiences are really different. So we need to recognize that. And I know a lot of individuals will say, well, that's too much work to get every single First Nations and Métis and Inuit cultural group into some of these spaces, but we have to find ways in which to understand the limitations, but work within them and try and work where people are at. So with the second question here, what does community-driven and accountable health research look like in practice, and can researchers ensure that their work reflects community priorities rather than academic priorities alone? I think when I was listening to the presentation before, I think we're beginning to see ways in which this is happening. When we look at research priorities or looking at projects, if we're looking at a community-driven project, we should be working with the community before the project even starts. We should be engaged there to see if it is actually something that is important to them, and how this works, and how we want to go about building the entire research program. One of the things that I've been working on with students and communities is we shouldn't be working at what is the question we need to ask, but rather what is the outcome that we want to see coming here. So what is it that we want to actually develop, create a knowledge mobilization to work with the community, because that can actually begin to move the entire research program in a totally different space, but it provides an opportunity for the community to have control and the researcher to begin to work with and begin to build relationships with the community at the same time to get the research that they need. Now, this is a little bit different when we're looking at bench science and we're looking at different things, preclinical trials. Totally understand that. But we need to, if we're looking at preclinical trials, Wendy Marks, who's part of the Saskatchewan NEIHR, is doing some really interesting work in what she's working on. She's looking at how do we develop preclinical trials with community, making sure that and she's working with animals and so forth, but making sure that those animals are treated with specific respect, because some community members are saying if they're not treated in a good way, then that medicine it's tainted. It's not going to be good for us. And we need, if these are our relatives, we need to make sure that they're being treated in the best way possible. So she's really working with community to begin to design different ways in which preclinical trials are designed for First Nations, Métis, and Inuit people, and working in that space. When we do this within research, and it takes time, and it's not easy, and we have to realize that is when we build relationships and ethical relationships with communities and community partners, once we start that foundational piece and it is built strongly, research just, it derives from it. They're there to support you. We see different ways of doing things, but if it's done in a poor way, that's where these research partnerships and research engagement and research just stops and it gets halted. So we have to understand, I believe that as researchers, we really have to come in with a notion of humility, a notion of understanding that we don't know what's going on. We have tools in our backpack that we can go to help explain specific phenomena in a way. And we want to work with you to make sure that we have a better understanding to improve your health, improve health, not just of your community, but other communities that can learn from you. One way I think, and this was alluded to in the earlier presentation, is the notion of relational accountability. Looking at the idea that every time you go into a meeting, you're building a relationship, but that relationship has to first be built off of respect. Now, a relationship that has respect means that I respect you, you respect me, and we're going back and forth. Doesn't mean we have to agree on everything. Doesn't mean that we are always in good space, but we have to have that idea of respect. And respect means that we should be able to talk openly with one another when things are going wrong or when things are going right. The next is relevancy. So we want to build relationships with respect, then, and when we have relevancy, that means that they're ready for the research project or what we're trying to do, and we're ready for where they're at. So it has to be relevant to the community. It just can't put research for community's sake anymore. And that's what communities are asking for. It's no more of this just helicopter drop in, do your research and leave. It needs to be relevant to us. And what does that look like? That's where those conversations come in. The next piece is reciprocity. This doesn't always mean, and we have to be careful of this and why it's important for distinctions based. Reciprocity also means like, what are the cultural protocols that are involved in knowledge exchange and bringing people together? One of the biggest ones in Canada is tobacco, but tobacco is for First Nations. It's not used in Métis communities and it's not used in Inuit communities, but we see individuals just say, okay, we're going to give elders tobacco. Knowing the community, knowing what's going on there will help you begin to understand the importance of reciprocity within those communities. What is it that builds that relationship that's going back and forth? When we look at this, a lot of times as researchers, we will get promotions, we'll get merit, we can do a bunch of different things. But what is it that the community also gets out of this? So if there's a new drug or a new procedure that's done where there's a profit that happens, is that something where we need to develop a licensing agreement with the community? What does that look like? What does that reciprocity look like in there? And the final one is respect, making sure that you respect the information and the knowledge that's been shared with you, but also making sure that researchers are respected by the community. I don't want people to think, oh, it's always the researchers that are negative. Sometimes we have communities that are not respecting researchers. And so we need to make sure that that relationship is in a good standing, in a good way. So when we look at community-driven research, that's kind of where the foundation is, that if we don't have that, we won't be able to actually move forward in a way that is actually innovative, because then we're going to get stuck in our own way of thinking of what we believe is innovation. And it's coming together as a community. That is where true innovation begins to occur, because we can bounce ideas off of each other and in a way in which that we can say, how do we begin to see this issue from a multiple lens and work together to find the best solution for us moving forward. Finally, the last thing that I was asked to kind of talk about is, what have I learned about creating pathways for Indigenous students and community members to become leaders in health research? The NEIHR program is not new. It's actually a reiteration of the older NEARs, or the Network Environments of Aboriginal Health Research, which was a part of the cadre system before. I was a part of those old NEIHRs, and we were funded and we built up capacity to a point. And then in 2013, the NEIHR program was shut down. Then it took another 5 years to rebuild the program. And now we're, after that, in 2019, they came back. And now we're at a point where we're at the probably the same level where we were when they began to shut down. So it took us 5, 6 years to get to a point with the capacity again to work with CIHR, other institutes, and internationally to understand this. So we need to find, and what we're finding with this within the mentorship pieces is that a lot of Indigenous students don't feel safe in labs because they're the only Indigenous student there. This would have been, if we look about 30, 40 years ago, when women were starting to move into labs, it wasn't safe for them as well, because it was a primarily patriarchal space where then they got asked to explain and be the token of what's happening. We're seeing the same thing happen with Indigenous students, that they're the token, or that they're, when they're asking a different question or seeing things in a different way, that they're not being supported. What the NEIHRs are trying to do is trying to support these students and create cohorts for students to begin to know that they're not alone in these spaces. And that's where the importance comes in, because once they find out that they're not alone, that there's this larger networks of individuals who are Indigenous, non-Indigenous, who are working in a space to improve and support Indigenous health research, we're starting to see an increase again in Indigenous health research capacity, where we're now moving beyond capacity to bridging. We're not looking at developing capacity. We're now bridging across these spaces, and where we already have the individuals there. We're working on building these relationships and building these foundations again to really push the needle and have Canada be a leader in Indigenous health research. which we have been seeing, and we continuously want to push into this sort of direction. So, and I know you didn't have a break, so I'm going to end it there so that you can all get a break, and everything else. And I just want to say thank you for the opportunity, and I am here for any questions that anybody may have.
Thank you, Dr. Henry, so much for this really wonderful conversation. I know it's definitely opened my eyes to the importance of involving Indigenous communities and partners from the start, building that strong foundation like you talked about. So I invite everyone in the audience to share any questions or comments you might have for Dr. Henry. You can drop them in the chat. You can turn on your mic and camera. So I'll give everyone 10 seconds to maybe raise your hand if you want to do that. But in the meanwhile, I definitely have some questions for you, Dr. Henry. It was a really insightful speech. And my first question is kind of in regards to building long-term, meaningful relationships with Indigenous partners, like you talked about. So we know that that is very important. And we know that researchers are sometimes working with academic timelines or funding or grant program timelines. How should they plan to build these long-term, authentic relationships with Indigenous partners while also kind of meeting the requirements of these timelines?
Yeah, so that's a great question. So one of the things that we do with the NEIHR is we actually are supporting small community partnership grants and knowledge mobilization grants. And we're working on this, and it's going to be a long-winded answer, but I'll get to your point. Trust me on this one. Um, we are understanding that the research cycles don't fit with community needs and things change all the time. So if we can start using the NEIHRs or other research spaces as creating small research funds or funds in order to build these relationships, we can start creating very strong research plans for when the cycle comes through. With the with the Saskatchewan NEIHR, these are $10,000 funds that are intended to bring people together, talk about an issue that's related to the community, with the researchers going in there and start developing a plan on what they would like to see. And so creating a step wedge approach that this is going to happen. We also know COVID-19 has taught us different things, good and bad. Good is that it opened up some valves for research flow and information and funding to get flown very quickly from place to place. But it hasn't been done in sort of the social quantitative space of working with communities. It was more of labs being able to share information in that. What we've done, what we're doing right now with the Saskatchewan, with the NEIHRs, the Network Environments of Indigenous Health Research, is we last year with the wildfires that came through, I actually worked with NCIHR and Center for Pandemic Preparedness, to create and to explain that we need to understand what's happening in real time. We have to be able to do this because when we look at Indigenous life, like a lot of times people are there for a short period and then they're gone. And we're looking at, so what we did is spoke with them to say we need to find a mechanism in this. What happened was we applied for the rapid response research to wildfires, which is actually designed around a notion of how do we develop rapid response research methods and methodologies for specific communities, and how does this work? So where I'm going with this is that we need what we need is we need to get out of our offices. We need to get out of our silos and stop thinking of people coming to us, but going out into the community. Like if there's a community event, just go and make relationships. Take your time to do this. And again, realize that not everybody has to do this sort of research. Like that's the thing. It is a specific way in which to build these sort of pieces, but we need to really kind of focus on making sure that we have the partnerships in place for when these granting calls come down and be ready for them and really try and work with the communities and for communities to begin to understand as well that these are competitive. Like right now, it's every third time going through for CIHR project grants, that's the success rate. So by the time you get your third round through, there it is. So that's three. It's going to be turning into almost 3 years here anyway with the new changes that are happening, if that happens, or a year and a half before you even get your funding going through. Now, when we have individuals who are on dialysis or looking for transplants and all of that, we may actually lose an entire cohort of the people who wanted to participate because they passed away during that whole time. And that's something that we need to work with CIHR and advocate on how do we move this a little bit faster, or what are ways in which we can change those funding mechanisms, or how do we find other sources of funding in order to do the large national products and do that sort of stepwise approach.
Thank you, Dr. Henry, for that response. Definitely working with these timelines can be tricky. They don't quite mimic the real timelines and needs of communities, but you've shared some really useful and helpful tips, I think. So seeing no questions in the chat yet, I have a second question for you, if it's all right. So you've spoken about the importance of going out to community, learning about different philosophies, different unique philosophies held by different communities, not, applying a pan-Indigenous philosophy to any research tool. So when we're developing these individual and specialized research tools or knowledge mobilization tools for specific communities, how can we make sure that that community has meaningful ownership over that tool and that personal philosophy or community philosophy that was used to build it?
Well, I think this is where OCAP it's good what you can learn from it, but don't apply it, but to every community. But I think what you need to do is you need to sit down and develop that sort of memorandum of understanding. And you do that from the beginning. What is the role within each person? What is the role of the researcher? What is the role of the participant? What is the role of the community? Is there an ownership? Who owns the information in the end? So when we look at this and we look at large data sets, that would probably fall under the leadership, that it would go to the leadership. But when we're looking at hard-based research or qualitative research, where it's an individual story, that story belongs to the person. And so as a researcher, this is where you begin to aggregate things up and say, okay, the story is yours. We can take 30 stories and then begin to aggregate this up to say, here are the themes. Then we can present that to the community. And it's an education piece as well for communities and researchers, is to really make sure, okay, who we need to define who is the sole proprietor of the information that is being shared, the knowledge that's being shared, and then work from there. And so that's where a lot of the work I do, I just start with the individual and say, where would you like to share it? Because of my work, it's not, I don't do large surveys. I'm not doing cohort studies right now, but a lot of it is understanding experiences, lived experiences. And so it's making sure that we protect that level first and then aggregating up. So every method and methodology is a little bit different, and that's that relationship oriented to the community, understanding who's there, understanding governance models, because you have to understand that leadership changes, and that's why you should have these MOUs in place and agreements in place, so that if leadership changes, it doesn't impact the research project that's going on right now, where you're renegotiating this all the time. So you need to make sure that those are all in place beforehand. So that's how I would go about doing a lot of that.
Thank you, Dr. Henry, for sharing that approach. Absolutely, that sounds like really great advice for other researchers who are looking to work with communities, and sort of taking that individual approach that you talked about is a helpful way to go about it, for sure. So, I'll ask the audience, one last time, one last call for any questions you might have. And I see that Dr. Tate has a question, if you'd like to go ahead.
Yeah, hi, Bobby. Of course, I have to ask you a question. So and I'm sorry, I came on late and maybe you explained this, but something that comes up in organ donation and transplantation research is that it's very patient-centered oftentimes, and this is a patient and family forum. And what I have seen is that there is a bit of confusion around what constitutes data sovereignty in relation to the partnerships, right? So can you have a partnership with just patients alone that are First Nations and Métis, or do you need to have a partnership? And maybe you've covered this already, but do you need to have a partnership beyond that with the leadership of a region or a community, and why is that so?
So again, I think it kind of goes with Sarjana was asking and how I tried to explain it there a little bit, but it might not have been clear. When we're looking at patient and specific patients and family, they're the ones who the data should stay with them. What happens is that when we start aggregating it up, and you and I have had these conversations, when we start aggregating it up to a secondary level, I think that's where we need to work with communities where it's at, because we need to have policy change. Like when we're doing a lot of this research, the patients and the families don't have the political power to make the policy change or advocate on behalf of that. So that's where the discussions really need to be said, is like what can be shared to the next phase. And I don't think that communities, like political bodies, should be involved in personal research, but as researchers, we should explain that we're doing research with your citizens in this area, and this is how we're going to share it. Like, this is the process that we're doing. We're working with them. They're going to share the information that they would like to share. This is the next level, and that's how it is. And some communities may say, like I know MMF, you can't do anything. They want 100% control of every single piece of data, no matter what happens, no matter what citizen and everything else. So I'm working with a couple students there to say, well, you're only working with 4 or 5 people. They can't say that this is their data and they have to be on every single publication of all of this unless the people say yes, that's what it is. And I think that's the complexity, is that we need to understand the local and regional politics. We need to understand who has jurisdiction at a level where policy change can happen. And we need to work with our participants, our research participants, um, to explain this is what's happening, this is what's going on, um, and making sure that they are protected, because I feel that the individuals who need to be protected most are the participants. And it doesn't matter what is going on. That would be the same as like Canada owns. You're not allowed to do a research project unless Canada approves that you can do this research project, and all data goes to Canada. We would never agree to that as Canadians. So we need to engage with this within our own First Nations, Métis, and Inuit leadership as well on what is research and what's happening.
Well, thank you very much, Dr. Henry, for that response. And thank you for sharing your knowledge and insights as a leader in the space of the distinctions-based approach to Indigenous health research. You've really reminded us all, I think, today how meaningful and how important it is to recognize and understand the individual identities, philosophies, priorities, experiences of different Indigenous communities and peoples. So thank you so much for your time and for making the effort to share these insights with us today. And a huge thank you to you on behalf of all of us as the CDTRP Patient, Family, and Donor Seminar today.
Thank you for having me today. Good luck for us. Conference.